Hi everyone. Today we're grateful to be joined by Dr. Andrew Beck. Dr. Beck is a pediatric hospitalist here at Cincinnati Children's Hospital. After attending Yale for undergrad, he earned his MD from the University of Pittsburgh and his MPH from Harvard. He then went on to complete both his residency and fellowship in general academic pediatrics at Cincinnati Children's Hospital. Dr. Beck is an accomplished community health researcher with particular interest in quality improvement, healthcare disparities, and social determinants of health. He played an integral role in Cincinnati's pandemic response by using real-time COVID-19 data to guide hospital response. In addition, Dr. Beck and his collaborators published a paper early during the pandemic which explores the link between racial disparities in COVID-19 outcomes and air pollution exposure. So thank you so much, Dr. Beck, for joining us today to discuss the epidemiology and public health behind the COVID-19 pandemic. I'll let you take it away.
All right. So thanks, everybody. Thanks for that introduction, Nora. And I'm happy to be here today. What I would say is this is certainly free to be as formal or as informal as you would like. I do have the chat open, so if you have questions or thoughts that you'd like to raise during the course of the hour, please just type them in or speak up, and happy to get to them. And I think what I'd like to do today is to really go through some key epidemiologic points that that have been raised and have been front and center during the course of the pandemic, and also illustrate some of the approaches we've used to inform the response. And so with that in mind, I'll present these objectives. So first, we'll talk through a few key epidemiologic constructs that are relevant to tracking pandemic phases, and we'll talk through how they could be defined and then how we might use them. We'll then illustrate the degree to which background context influences one's experience with COVID-19. That gets at some of the concepts of equity and COVID-19. And then lastly, I'll discuss a bit how we've used the concept of a learning health system and that type of approach to manage our regional response, and think a little bit about how what we've learned here over the last year may have applicability not just through the end of the pandemic, but also to other complex problems that plague our society. Now, to start, let me return back to a figure that we thought a lot about and looked at quite a bit early on, back in March and April of 2020. Some of you have perhaps seen this figure or a version of it. The hyperlink to the article that accompanied it is below. And this was shared widely in the early days of the pandemic, which provided us with the so-called phases called the hammer and the dance. So let's look at this. Today begins kind of the onset of the pandemic, but this was really something that was published out there on Medium back in the spring. And the thought was that if nothing occurred, then you would see a steep rise in the epidemic curve, whereby we see more and more disease, and it just kind of spreads like wildfire. Now, if you did minimal mitigation, perhaps you would shift the slope of that line to another degree, but you would still see that uptick in the epidemic curve, and a way in which we would see us kind of move forth a pandemic as it spreads rapidly across a population. Now, Tomás Pueyo, who provided this depiction in this article, said what ultimately we should do is start with the hammer. This is aggressive mitigation efforts that decrease transmission to a degree whereby we can keep the pandemic under better control. This is the so-called flatten the curve mentality. Once we reach that degree of mitigation to a point where spread is lower, then we can move into what's called the dance phase, where we kind of move between mitigation strategies like testing, contact tracing, quarantining, and isolating to keep transmission at a low enough point until either the pandemic burns out or we vaccinate enough to reach herd immunity. So this was the theory. You can appreciate the hammer and the dance and perhaps glean a little bit about my musical tastes. Anyone know who the guy on the left is? I'm just curious if anyone wants to chat it in. No pressure if you don't. I'll give it 3 more seconds to see if anybody chats it in. I don't see anything, so we'll move along. That is Pete Seeger, who's one of his many famous songs is "If I Had a Hammer." So there's this idea of like, let's really hammer this down so we can move on. Now, the problem, of course, is that did we ever truly flatten the curve in a meaningful way? Admittedly, the answer is probably not. And so let's think about how the kind of hammer and dance mentality figured into the context for our regional experience. And as we began to understand reality, we understood that if we truly wanted to achieve a flattening of the curve and pandemic control, we would require nimble and collaborative approaches that didn't really exist at the time this all started. This often would require big decisions that weren't just made by single institutions or single sectors, but were truly multi-institution or multi-sector. We came to understand that the data we had available to inform those decisions was quite insufficient. So oftentimes we had global, national, or sometimes state data, but although critical for overall understanding the degree of the spread across the globe, a nation, or a state, it wasn't always sufficient to make regional or local decisions. And in fact, the disinvestment in public health infrastructure and overall epidemic surveillance capabilities proved to make that early hammer phase quite difficult, made still more difficult by fragmented leadership, particularly between healthcare, public health, and other entities that are health relevant. So how did we begin to approach this early on was to say a measurement approach was critical. What we needed to understand was the degree to which we were seeing things shift and the ways in which those shifts could inform policy and strategies that crossed sectors and institutions. And so early on, we wanted to agree on a shared objective. So what is it that we were collectively trying to accomplish? What decisions needed to be made and how quickly? What was the theory we needed to develop or uncover to make the most informed possible decisions? How could we use measures to be situationally aware to understand, again, the degree of the local and regional state of COVID-19? And to do that, we needed to operationalize and define measures, source data sets to quantify what we could bring into the regional purview, iterate routinely to ensure that they were of use to end users and stakeholders, and be able to adapt to ongoing phases of the pandemic. So we're going to get into some of those strategies in a moment, but I think a point to underscore is that that operationalization and theory development was not occurring in a vacuum, that it was truly occurring during the midst of rapid changes in the picture of COVID-19, not just here, but across the world, where we started, if you all remember last spring, with this kind of flatten the curve picture. How could we ideally get to the hammer phase, but at the very least control things in such a way such that we could gradually reopen? And so March through May evolved to that reopening phase, perhaps too quickly, because soon thereafter we entered surge phases, which encompassed July and then again in the fall and the winter. And then now we're in this midst of vaccination initiation phases, while at the same time worried about the oncoming presence of variants. And so it's this rapidly evolving picture that we need to understand and then adapt to. And so if you think in parallel to these changing pictures, we had to shift, initially perhaps a focus on the elderly. Now we're perhaps shifting more toward younger adults. Testing initially was hard to do because we didn't have the appropriate kits. And then all of a sudden it became ubiquitous. So how could we then increase testing to an important degree as quickly as we could? What about PPE? Early on, it was scarce in some places, but available in others. How could we shift that supply to where it needed to be? mobility, questions about social distancing. What is the narrative by which we encourage the public to be safe and to remove some of those risks of spreading disease? And in fact, if you look at the social narrative over time, some of the ways in which that communication has occurred has evolved in and of itself and has had to adapt still more to the so-called infodemic of conspiracy theories and false news. So just again, to see this evolution occurring, this is, early on what we were looking at in March. We had emergency declarations and bans on gatherings. We had canceled elective procedures that led in April to these closures, continuing this worry that we were going to have to open the Duke Energy Convention Center as a community hospital. Things started to look a little bit better, so we started to see that phased reopening at the same time as we saw protests in support of racial justice. What was that going to do to the spread of disease? Soon thereafter, in June and July, we saw continued reopening, this masking that was perhaps insufficient, followed by the July surge. So again, population situational awareness that was occurring on the fly. And I say on the fly because in many respects, we didn't have the infrastructure available to do this. Now, I doubt probably none of us had really heard of this act before we started to go through the last several months, but there actually was an act of Congress back in 2006 called the Pandemic All Hazards Preparedness Act, which attempted to develop the relationships and infrastructure needed to respond quickly to pandemics like this one. In fact, a quote pulled directly from the text of this law was that it sought to establish a near real-time electronic nationwide public health situational awareness capability through an interoperable network of systems to share data and information, to enhance early detection of rapid response to and management of potentially catastrophic infectious disease outbreaks and other public health emergencies. I will tell you that this has not been our reality. And in fact, the GAO said just a couple years ago that we've not really made much progress as a nation with respect to such preparedness readiness. And what we found early on was just this, so that some of the data that was entirely important to some of that early decision-making, whether it be in the healthcare realm or in public health, was decidedly separate from one another. So if you think about within the healthcare sector, some of the measures that were quite important early on were concepts of utilization. So what did our hospitals look like? Testing, how often were we seeing positive COVID tests coming back positive? What were our resources? What did our PPE supply look like? And what did that supply look like in hospital A, B, and C? In public health, there were other questions about what about cases? What about positive reported contacts? What about deaths? All of these data were inherently separate. And when you thought about the need for a regional response in our part of the world, southwestern Ohio, southeastern Indiana, northern Kentucky, we truly needed to bridge this divide to achieve that population health situational awareness that the Pandemic Preparedness Act purported to support. But of course, there were challenges. Data were often at too large or too small a scale to be meaningful. As I mentioned before, sometimes we knew what was happening around the country, but we didn't know what was happening in our own backyard. Or we would know what was happening in hospital A, but not hospital B. Often there were delays. We saw manual entry and faxing and all sorts of things that were remnants of the 1980s and 90s, but were not a 21st century solution. We also saw data that were misaligned and defined differently if you were in point A or point B. We also saw a poor integration of leadership and infrastructure, a lack of financial support, and indeed incentive for collaboration, which made it difficult for us to get where we needed to be when disaster struck. So some of the early on solutions that were put into place and enabled us to pursue some of the epidemiologic measures, which I'll introduce next, were to leverage existing data infrastructure. So we had what's called a health information exchange in this region, which is essentially a link between electronic health records of all area hospitals. We had organization that came together with public health and healthcare systems together to ideally enable transparency and communication. We quickly developed some sample measures and metrics and provided those to key stakeholders to understand if they met those needs. And then we developed that networked approach that put everybody in the same room at the same table looking at the same data to try and make the best possible decisions for the region. Now I'll show you some of those data, but first I wanted to at least define some of the fundamental epidemiologic metrics or measures that we've put into place over time and that have proven quite important to understand the degree to which the pandemic is raging or cooling. And so let me start with the first one, probably the most kind of fundamental epidemiologic measure in the heart of a pandemic, and that's the concept of incidence. Here we'll call the count of incident infection, we'll call it I. This is the number of new infections in a given time period. Now, as I'll show in a moment, the time period can be tricky. Some note that this is new cases per population per day. Some note new cases per population per week. And some note new cases per population for a 14-day period. In fact, a day is what we've been using in large part here, but the CDC often uses week, and Ohio often uses a 14-day period. Now, the data sources for this have varied also during the course of the pandemic. We've often used data from national sources that pool health department data from across the country, but that can then be disaggregated. That's sites like the New York Times and Johns Hopkins. But state health departments also have that available. The CDC now has it available, but they haven't for the entirety of this pandemic. The reason we've often chosen to use sources like the New York Times is because it makes it a bit easier for us to disaggregate across a multi-state region. So recall that Greater Cincinnati includes parts of Ohio, Indiana, and Kentucky. By using a singular data source, we can disaggregate and get those county rates for the counties that are in each of those states. So incidence is a fundamental measure, but it's important to also think about it in the context of something called R. This is the effective reproductive number or ratio. This is defined as the number of infections caused by on average by an infected person throughout the course of his or her infectious period. So in other words, if I came down with COVID-19, R would be the number of people I would go on to infect before I either was no longer infectious, I recovered, or I died. Now, R can be thought of in terms of a disease that is introduced to the population and the population that has never seen that. That is what you may have seen in the news is R naught. That is, if no one has ever seen disease, if there is no immunity to that disease, what would R look like? And so when SARS-CoV-2 or COVID first hit, the thought was that the R would likely be somewhere in the realm of 2 to 3. So rather infectious. If you are above 1, you're going to see a rise in incidence that follows exponential pattern. If you are below 1, you're going to start to see decay, and in fact, that will follow an exponential decay. But there's another way to look at R after a certain amount of the population has either been affected by the pandemic or is vaccinated, and that is so-called R sub T, or this effective reproductive number, where here we see the number, it's no longer 2 or 3 per se, but where it is will define whether we see that exponential increase or that exponential decay. Now, the importance here is to look at both I and R together because I provides the context for R. If you had a population of 1 million people and today 3 people had disease and tomorrow 6 people had disease, your R may look problematic because you saw that transmission occur. But your I per population is probably not all that worrisome. And so it's important to look at both simultaneously, the number of new cases per population over a given time period, and a measure of transmission, that being R, how many people on average an infected person will go on to infect during the course of their disease. At the same time, it's important to track key planning measures, of course, that relate to broader context, like hospital volume, deaths, testing, and vaccination, to help understand where you're going with respect to meeting the need of the pandemic, ideally reducing a time-varying incidence and getting that R under 1. So we're going to get into some of the specific data, but do those constructs, I and R, make sense? And I can't see video, but does anyone have any questions or points of clarification to put in the chat? Okay. So where are we? What I want to do over the next several slides is briefly go through the state of COVID-19 in Greater Cincinnati. Much of this data is published on a daily basis on the CCTST website, which is here. I pulled these data from our update last night. So these are, tonight's update hasn't come yet, but these are pretty darn up-to-date data. So we'll just kind of go through one by one. So this is the first set of charts. You're looking at 2 measures here. The top one is a measure of R over time, and the bottom one is a measure of I, or incidence over time. On the left, you see Hamilton County, and on the right, you see our 14-county region, which again includes 8 counties in Ohio, 3 in northern Kentucky, and 3 in Indiana. And so a couple things to look at here. So both are varying over time. You see, this just goes back about a 90-day period. So we're going back towards January. And what you can see on the R chart for Hamilton County is that for a good bit of this part of January, we had an R above 1, indicative of spread, a meaningful transmission of disease. But happily, that number came down. And for a good bit of the last number of months, we've seen that R value be below 1, which aligns with this downward trend in incidence. You see, we were up here at an incidence of about, between 50 and 75 new cases per 100,000 population per day on a 7-day moving average. But we've seen it come down nicely over the course of the last couple of months. Now, I will note here that you see some uptick in R over the last couple of weeks. And in fact, I'll advance to the next slide. These are not county data, these are state data. And you see that R is now significantly above 1 in Indiana, Ohio, and across the United States, all concerning as it could portend an increase in transmission and an increase in incidence. What are some reasons for that? Well, we don't totally know, but we have some theories. Could it be the emergence of new variants? We know that many are present across the country. Could it be a reduced adherence to social distancing and masking guidance? Could it be spring break? Could it be that we are now starting to see the end of the decrease in effect for those older individuals who have been vaccinated, but not as much on the younger individuals who have not yet received their vaccination? All questions we're trying to answer as we speak, as we see, again, a rising R with the concern that our case numbers are going to start to rise once again. Just another way that we look at incidence. These are charts we share, widely, but also with our schools. The red, orange, yellow, green here come from guidance out of a group at Harvard for how to think about low, medium, and high risk levels for incidence over time. And you can see again the trends here that we were in the red not too long ago. These are a 30-day frame. And we've kind of gotten stuck a little bit in the orange according to these TTSI levels, which is the Massachusetts Testing, Tracing, and Supported Isolation Collaborative. Again, concern over the same questions or the same potential reasons that I was noted. Oh, I see the R calculation. Yes, so R is calculated through differential equations. There's far more complexity to the actual calculation that I can speak with intelligently. But into that calculation goes key intervals or lag times. So how often on average is someone capable of transmitting the disease? How long is the kind of latency period between when someone is exposed and will be infected? What is the degree to which that transmission is likely to occur in that period? A series of equations that are modeled to get to that specific number. Now, some of those values we know, others we have to estimate from other diseases. And influenza is a common example of one that has been useful in the developing of models enabling the calculation of R. But it has to do with those kind of touch points and lags within the timing in which one can be that one can be infectious. So I want to show the same data a different way. And so, again, if you toggle back and forth, this is the exact same data. But this highlights one of the challenges we've been seeing, that different groups have been providing guidance on cut points, have been showing incidence in different ways. So this, this was the Harvard group, the TTSI group. Like I mentioned before, at the start, there was not much great evidence, nor were there great guidelines from federal or state sources on risk levels. And so we went with this one early on as it seemed to make the best sense and had face validity. But just a couple weeks ago, the CDC finally came out with guidance on school reopening and what it meant to have high, medium, or low levels of incidence. And so this is the depiction of the same data, except with their cuts. And you see the numbers look different. These are, instead of a 7-day moving average for a single day's incidence, this is a week's incidence. So it's merely the number I showed before times 7. So it's good to be able to understand how exactly even incidence is being calculated to be able to compare across guidance. Now, again, incidence is a measure of new cases over time per population. One of the other ways we've looked at it is by age group. So here we've just looked at incidence, but cut by population. And you can begin to see that in general, we've seen decreases that look very similar across age groups. But the child age group has often looked a little bit different. And this has been something that we've tried to pay close attention to, particularly as schools are thinking about reopening or making decisions about how to go back to in-person learning. We've also paid attention in some ways to the flattening that we see, and the flattening in age groups that perhaps are not yet exposed to vaccination. So this, again, may add some credence to say, well, are we seeing flattening because of a variant or because of almost like a ceiling effect on vaccination of older age groups? All questions we don't yet know the answer to. Now, of course, R and I, the reproductive ratio and incidence, are important, but when you're trying to staff up hospitals and respond effectively, it's important to also see the use of end resources. And so this is a chart that we capture and create from the Ohio Hospital Association, looking at all COVID positive patients in our regional hospitals. So if you look at the top figure, the extent of the orange bar is that number over time. The blue, which is a portion of that orange, is the number in the intensive care unit. And the green is the number on ventilators. And so overall, you can see that same effect aligning with the decreased incidence is that we have, on average, fewer patients in our hospitals with COVID-19, though we have essentially plateaued, that we are not moving downward as fast as we once were. And in fact, if you look at other parts of the state and other parts of the country, you see the hint that we're going back up in a problematic direction. And our hope is that that increase doesn't come to this part of the state, but by looking at this every day, we would have the opportunity to see that as quickly as we could. This is also looking at hospital beds, but these are looking at the number of occupied beds writ large, regardless of reason. So some of these beds are occupied by COVID-19 patients, but some of them could be occupied by any other reason. And this is important for us to know, just because if we are starting to see an increase in COVID-19 cases, we may need to understand how that would have an effect on our ability to take care for patients with heart attacks, or to pursue elective procedures, or to change staffing levels. And you can see the coloration here, green to orange to red to black, represents the true strain we would have on those staffing levels that could be problematic for our ability to care for patients more widely. Now, I see the question in the chat about estimating asymptomatic or underreported cases. This is an incredibly important point to make. We only are able to calculate these factors based on the cases we know. Early on in the pandemic, the likelihood of underreporting, making any data that was being presenting, the underreporting because we had so few tests being pursued, likely made underreporting a huge issue. It still is likely an issue that we expect the actual case counts to be far above where we are in reality. But one of the things that hospitalizations has allowed is thinking that that might be in some ways a leading indicator. So yes, there are different reasons why, or different presentations of COVID-19, and youth tend to not have as severe disease. But early on, when we were really worried about underreporting, we looked to hospitalizations and emergency department utilization as potentially a leading indicator of a rise in actual incidence. But you're right, there's no perfect way to account for that missing data that we just don't have access to. Which is one of the reasons why tracking percent positivity and tests over time is also so critical. So two values here. The top one is looking at the percent of tests that return positive, and the bottom one is looking at the number of tests on average pursued across the region per day. If you had a high percent positive and a low testing number, it's probably true that you're not testing enough. If you have a high percent positive and a high testing number, you're probably still not testing enough, but you also know that there's an excessively high burden of disease. If you have a consistent number of tests being pursued, or high numbers of tests being pursued, and a relatively low percent of them that are coming back positive, some of that question about asymptomatic or underreported cases becomes somewhat less important. So this is a key contextual variable on which to hang your hat. Here you see that our current percent positive is around 4%. That is pretty good. We like to see that number, I would say, as low as possible, but ideally below 5%. You can see that not long ago, the percent of tests returning positive was far higher in the 15 to 20% range. And just a couple more of these charts. This chart is looking at a 7-day moving average of COVID-19 deaths across southwestern Ohio. There is quite a bit of lag in how the state reports these deaths, so that recent numbers, as indicated by their shading and the dotted, the dotted line, we believe to be highly insufficient. That those numbers are highly likely to change. That said, you can see that the curve tends to follow what we've seen as the reality over the course of the pandemic, that we had an initial increase that probably underreported. We went down again until we went down again late spring, and then it popped back up to that surge in the summer. A slight decrease in the fall before we really surged as the fall and winter took hold. And then the numbers have looked better over the course of the last several months. One of the things we've also tried to leverage is data that has been made available by, in this case, Google, assessing mobility. So each of us, unless we turn it off of our functionality on our phones, can begin to help us understand where we've been and what we've been up to. And Google publishes these data every now and then. This most recent one is from a few days ago. So this is basically allowing us to see what we've all been up to and what we're all up to over time. And so they classify it in a few different ways. And you can see that as things kind of changed dramatically, all of a sudden we weren't necessarily going to retail or recreation. We weren't necessarily going to work. We were staying home. And you can see that over the last several weeks, we're starting to see more of a presence at retail and recreation that may be some of that decreased adherence to mitigation strategies. I'm looking at the chat. Can we learn anything from last year's initial peak? So the question relates to the peak that we saw last spring, the questions about weather. Yes, we can learn from that. We can certainly also learn from experience around the world. The thought was then that being outdoors helped quite a bit, helped lessen the degree of spread, lessen the degree of transmission. But I think at the same time, we saw restrictions relax a little bit and people get back into closer quarters come summer. And so, it's this kind of multifactorial set of factors that comes together to think about, like, why are we seeing ups and downs? I think there's theory about weather, but I think social proximity, adherence to masking, and COVID fatigue has probably been the thing that has been the set of things that's most consistently led to why we've seen increases or decreases. But now, of course, vaccination is something that's taking hold also. And so we're tracking for the individual counties and for the region, numbers of vaccines pursued over time. Here, the blue lines are the vaccines per day. The orange are completion per day. So either your second Pfizer or Moderna or your single Johnson & Johnson. And that's enabling us also to show the percentage of the population that's been vaccinated over time too, Hamilton County versus Ohio. You can see that as of yesterday, about 28% of our county's population has started their vaccination. We're working closely with the state and others to try and think about considerations of equity as well. So what is the rate at which vaccination is being pursued by race, by ethnicity, by age? We're trying to get better data into this right now, as is far too often the case. Race and ethnicity data are missing far too often, so it becomes difficult to come to a discernible conclusion on what that could look like. We also don't know the breakdowns of who has been eligible and who has had uptake of those vaccines. So for instance, when eligibility criteria had individuals who were, say, over 65 eligible, we have not been able to look at both age and race at the same time. These are all ongoing conversations with the state to try and get better data, but important for us to understand so that we can ensure an equitable distribution of this important resource. To that end, we're trying to think about where vaccination is occurring, much like we did with testing over the course of the last several months. Where are vaccine sites, and where, how do they enhance access for those who are either of low socioeconomic status or racial or ethnic minorities who may have different degrees of access to other health promoting resources. This is a map of Hamilton County with the colors depicted the varying degrees of poverty, and then the vaccine distribution sites noted with their vaccine number capability, kind of small, medium, or large, all helping us to understand how, where, and when to best distribute those vaccines. Now, I did just want to spend a moment on COVID-19 and equity. It's foundational to what I was just showing, but it's also a piece of the larger puzzle. That early on, Dr. Nicole Arrett, who's a public health professional and professor at the University of Washington, highlighted in a New York Times article that these things, being pandemic and poverty, are so interconnected that social vulnerabilities only get worse following a disaster. And in fact, there was much written and much noted about the equity implications of COVID-19. This, I thought, quite instructive and interesting piece from the NAACP back in March of last year highlighted 10 implications to specifically call out for COVID. The potential for increased racism and stigmatization, particularly early on, that certain populations had an added risk of exposure, as well as other impacts related to the pandemic. That social distancing can often be seen as a privilege, as not something that was equally easy for everyone. This being the year after an election year, we saw the impact both on census and voting. We saw potential increased exposures to toxic cleaning chemicals, at least in certain locations. That school closures led to perhaps excess food and housing insecurity that were differentially experienced. That early on, there was a lack of accessibility to testing kits, so who was getting tested? The risk posed to human and civil rights, particularly as it pertained to quarantine policies. What did that mean for immigrants trying to cross the border legally or with humanity? And then the infodemic I raised earlier, what would misinformation do to the outbreak, and how would that affect individuals' experience with it? And what's good about this piece is that the NAACP provides examples of what we can collectively do. Again, this is somewhat outdated, but it was incredibly relevant at the time and should be important for us even throughout. Important to change the narrative and not stigmatize this disease, to increased access to health promoting resources and equity promoting resources, and to think through other ways in which we could prioritize vulnerable groups and populations for testing. Here, I would say that extends to vaccination now. And the reason this is so important is because we've come to see the degree to which COVID-19 and race and ethnicity intersect. The data from the COVID tracking project note that nationwide Black people have died at a rate 1.4 times that of white people since the beginning of the pandemic. In Cincinnati, we see that although Black individuals make up roughly 40% of our population, they've experienced nearly 50% of deaths. And according to the CDC, there are some potential theories about why that perhaps we all could answer, but specifically they call out many of those things that show up on that NAACP list, like differential living conditions that make transmission higher in some areas than others, work circumstances that often place underprivileged individuals on the front lines, underlying health conditions that have long been present that themselves are indicative of differential social determinants and contexts in which people are born, grow, work, live, and age. And then differential access to care, whether that be for COVID-19 or for other factors that influence one's health. So with this in mind, as we thought about optimizing the regional response to COVID-19 in an equitable way, we turned to our partners, many of whom highlighted the importance of trusted messaging, to proactive approaches to prevention, not just of COVID medical challenges, but of non-COVID challenges related to meeting basic needs, obtaining food, education, et cetera. And then ensuring that equity was at the fore of all diagnosis and management decisions. And so we saw messaging take hold on social media. We saw masks on campaigns. We saw mobile markets that ideally brought food and nutrition to the neighborhoods that needed them. We saw basic needs bundles assembled and distributed, masks knitted by volunteers, and all things that frankly didn't look all that too dissimilar from what we saw back in 1918, or depictions of what we saw back in 1918 during the last pandemic. This last picture being taken directly from the Cincinnati Enquirer during the influenza pandemic now 100+ years ago. At the same time, the measurement strategies that we talked about earlier on have been critical. They've enhanced communications across sectors. They've built strategies for collaboration, whether it be on food distribution when schools closed for all those kids who get free reduced breakfast and lunch. It was true for testing site localization, for vaccination, and for school opening. And just as a couple examples here, I'll show this, a map that was developed by Charles Hoffman and others at 8451 and at Cincinnati Children's to aid in locating food distribution sites when schools closed last April. You can see a map of Cincinnati. You can see the green being buffered zones that would be well accessed by sites that we had available. We had additional sites added to meet needs that weren't necessarily met. You see a map here of Hamilton County and its neighborhoods that helped with testing site localization. Here were some early on public testing sites. We added a buffer to understand how many people would be within a 10-minute drive time of those sites. We overlaid community deprivation or poverty, understanding where the need may be the greatest to begin to locate additional sites that provide that additional access, that additional buffering to, again, help meet the need of our population. We're doing some similar things now with vaccination. Here are maps that we used early on in the phased distribution of vaccines when we had a guidance from the state to vaccinate those who were 65 years and older. We wanted to look to those zip codes with the highest number of individuals who are both Black and 65+, or those with the highest number of those living below the federal poverty level and 65+, again, to ensure that we were promoting equity in access. And as it pertains to school planning, we've built guidance atop best insights from around the country. We've co-constructed guidance with healthcare, public health, and school leaders here in Cincinnati, and we now publish this every week on this URL to provide with the latest data as well as strategies for reopening that bring the best evidence to the fore. As an example, some of the measures we use here are the same that we've talked about. Cases in the school, a measure of incidence, the number quarantining, some conception of mitigation strategies in use to, again, bring the in-school transmission or R downward. Aligned, of course, with community measures. So it's not just important what's happening in the school, but it's the context in which the school is finding itself, again, relating to incidence, concept of R, but also this question of test positivity to allow us to understand how we're doing, and working to align that guidance from CDC as we begin for fall planning, which may require us to do more surveillance testing. So in the last couple of minutes, just again, thinking about how these measures, how these public health strategies build toward a cross-sector learning health system that allows us to understand the totality of what we're doing, not just healthcare, not just public health, but truly the entire scope. And if you think about what that scope looks like, in this region, it involves thinking through 14 counties, 3 states. Within those counties and states, we have nursing facilities, there's prisons, there are shelters and halfway houses, there are hospitals, there are businesses, there are neighborhoods, there are schools and universities, all having to align around testing strategies, tracing strategies, and treatment strategies until the point where we are now, where we aim to get vaccination brought to bear. And so I'm not going to go through this in detail, but just as we would any improvement project, we started early on to try and put this all onto a single document to understand where on the system everybody found themselves and how they could contribute to the system in a meaningful way, how they could help to reduce mortality, reduce R to a level less than 1, while optimizing and maintaining economic vitality. And this is in some ways a document that provided a jumping off point for discussion, for alignment, and for ongoing efforts. It also led to something called the Multi-Agency Coalition, which still exists and meets weekly to understand the state of the pandemic, the state of COVID-19 in our region. It aligns those from healthcare, public health, and congregate care with infectious disease experts, laboratory operations experts, communications experts, and then the team that I sit on, the situational awareness and surveillance team, which brings in data and analytics, systems improvement thinking, this idea for knowledge sharing and learning, and deep community connections to maintain that focus on co-design and equity. This has allowed us to evolve through COVID's many phases, initially dealing with questions of surge planning, worried that the hospitals would be overrun, but over time thinking about additional needs and bringing in additional stakeholders to inform new phases. Design principles have been critical to understanding how to do this and how to be adaptive. The idea of engaging stakeholders continuously to co-design goals, measures, and theory. Integrating data streams so we have a single source for measures that can help us to all speak the same language. Using data to build shared purpose and overcome competition. Unleashing the inherent motivation all stakeholders have had to bring their insight and expertise to the best possible solutions. And then to establish this multi-agency coalition to allow us to maintain a multi-agency, multi-sector approach to optimize public health to outlast COVID-19. So just a brief summary. So I'd say that advanced measurement capabilities have enhanced our abilities to meet the challenge, but challenges remain. That this population level situational awareness has been critical to understanding the pandemic, informing responses, and communicating the ongoing need for mitigation. This is true for health relevant sectors as well as for the general public. And more than anything, perhaps it's underscored the need for greater preparedness for the future and for the idea that learning from multiple sectors will be vital to responding to complex challenges, be it another emergent infectious disease or other complex population health challenges that have existed far before COVID. Now, I presented lots of material here, many of which are data elements and measures that are worked on by a number of different people. There have been countless individuals who have contributed to responding to the COVID pandemic over the last number of months. And I certainly want to acknowledge those contributions and celebrate the efforts that has gone into keeping our region safe. I know we just have a few minutes left, but I'd welcome any other questions or thoughts. And then certainly if you have questions or thoughts that you'd prefer to ask separately, do send me a note after the fact. So thank you for your attention. All right. Anything else before we close? Let me see if I'm going to reopen my chat. So the question I see in the chat about the J&J vaccine. So this is interesting. This is there's not a great we have not seen many J&J vaccines here in Hamilton County yet. The likelihood that we will see allocation of J&J is likely going up, and we'll likely see more of it in the coming weeks, but we haven't had much of a supply as of yet. There are ongoing conversations about the point about how best to consider how to deploy Johnson & Johnson versus Pfizer versus Moderna. A specific question about how and where to do that hasn't been made yet. But I will say that likely the likelihood is that the best initial thought will be that the offer will be for whatever we have available. But currently in this region, it's almost entirely Pfizer and Moderna. And so we haven't had a situation where we've had to figure out where the allocation of Johnson & Johnson go. So there was a question about disparity about underrepresented minority groups and at lower SES groups when it comes to vaccine distribution. So we haven't really noticed this yet. Again, it's hard to truly come to a conclusion based on the data we have available to us. We've seen evidence that everyone wants a vaccine. We haven't seen it that there's been a differential vaccine refusal. So then it's been a matter of access. And so to date, the demand has been great, no matter which population subgroup that we're seeing. But what we are really pressing for with health systems and public health departments, and they're pressing for it too, is plans for equitable distribution. And so actually there was a call earlier today where every health system and public health department provided their plans for equitable distribution of vaccine. That is a foundational principle in how we're pursuing vaccination right now. And we want to ramp that up considerably, particularly now that all age groups are eligible to be vaccinated. Information accuracy. Control measures for information accuracy. Yes, we have standards we keep to for accuracy. I am not certain the degree to which ODH, Ohio Department of Health, goes through their data for accuracy, but one of the reasons we've chosen some of the data sources we have is because of the accuracy of the data, whereas at various points along the way, we have been concerned about accuracy, or if not accuracy, the true representativeness or time lags inherent to the other data sources. So it's something we pay close attention to, and some of the measures whereby we track information allows us to know pretty quickly if a point seems off, like it doesn't make sense. And if that's the case, we look into it in greater detail. I am not aware of anything to the degree that they noted in New York with nursing home related deaths, but I would be somewhat suspect of any of the early data that was collected, particularly around deaths, just about anywhere, given likely missingness within the data. And then a question about the Oxford Astrazeneca vaccine. I don't have much or different thoughts than what I've seen in the news to date. I think there's more data that needs to come out about that. If the data prove promising, then I'm sure it will eventually find its way into an EUA and again, up supplies. But I think there's more data that still needs to come out of that particular vaccine and trials inherent to it. Around here, we're most familiar, of course, with Pfizer and Moderna, and then clearly J&J growing. All right, guys. Well, I think we're a little bit over. Please be in touch. Let me know if you have questions or concerns, and look forward to hopefully talking more about vaccine and the end of the pandemic before long.